them here in this room, in this gathering. This symposium organized by RAB is trying to address a key question. And that key question is, how can health taxes be deliberately designed and used to support integrated district-level primary health care? To frame this conversation for us, I would like you to please join me in welcoming RAB Director, Russell Rensburg.
Thank you, everybody, for joining us in this conversation. I think I want to premise the conversation on two things. Firstly, I think we, as a constitutional democracy, have set ourselves great aspirational targets, right? In Section 27, we protect a number or guarantee access to healthcare services. We talk about access to food, and at the very least, social assistance to those that need it. Now, those rights speak directly to another goal that our system has, which is Section 10, right? The right to a dignified life. And nothing can be more undignified than not getting healthcare when you need it, right? Sometimes dying, never knowing that you had a healthcare need. And I think that's the story with cancer and diabetes, right? Not being able to educate your children, right, is a part of a decent life. We guarantee that in other parts of our Constitution. And our Constitution is a living document. It gets interpreted in different ways. And I think most recently with the publishing of the national budget earlier, was it last week? We got a vision of what progressive realization looks like in a state that consolidates. And the health system is a difficult place to sort of put that caveat on the progressive realization of rights. Because given our history, we actually had a very well-developed, publicly funded health system that was geared towards servicing maybe 20 or 30% of the population. And I think one of the difficult questions we have when it comes to budget making and advocacy is how do we have progressive realization in what some would call a universal system? And I think the budget sort of put the fish on the table. We can't achieve the outcomes we want, right? A dignified life, access to healthcare when you need it, at no cost to you, responding to unmet health needs that have built up over time, if we continue to fund health in the same way. But we face real pressures. We saw from the response from the economy and the business how great some parts of the budget was. Stabilizing debt over the period, having economic growth rising slightly higher than what it's been in recent years, and the trajectory looking good. But in terms of state capacity, like I think we say in our statement, was go back home and do some homework, find the efficiencies. We can give you limited support, but we can't fix your structural problems. And I think today, we are coming here today to start thinking about how do we fix those structural problems? How do we ensure that essential health services like access to reproductive, maternal and child health are protected and expanded? How do we ensure that the response to infectious diseases, which now also include a chronic care element, is adequately resourced, and also sufficient resources to take forward some of the amazing innovations within that space, like lenacapavir. With non-communicable diseases, we remember starkly from COVID that one of the biggest lessons that we learned, that almost every person that died, or every person with HIV or TB had a comorbidity from diabetes that came up in the numbers. We have a model study that tells us 5 million people or so are living with diabetes, right? But only 1.2 million of them are currently in care, right? And that became quite stark in the 300,000 people who died from COVID in the excess deaths. We also know that our country is a country of weird opposites, right? I mean, we just come out of December. And I think the thing that sticks with me the most is that we spend close to R1 billion a day on alcohol, right? Normally, 417 million rand a day on alcohol, right? We know from the stories and from the Gauteng Department of Health of access to late-stage cancer care that we don't have enough money to meet our immediate priorities in a list of a whole lot of different priorities. Why we have a tobacco industry that is being curtailed because there's illicit trade, rather than why was that tax designed, was really a public health measure to reduce tobacco consumption, not to control the tobacco market. Right? With alcohol, we also know that the high cost of trauma. Often, one of the statistics that I go back to every time the district health barometer comes out is interpersonal violence, and how it is the leading cause of death amongst young men between 15 and 25. And I don't think I need to remind anybody about the pandemic or epidemic of gender-based violence. But all of these things are abstract until we make them concrete, right? And in Treasury putting out guidance on strengthening efficiencies within the delivery of healthcare services, I think that opens the door for us to start thinking about whether the healthcare services we delivered are funded and designed in a way to respond to the broader needs of the population and not just the inputs that the health system needs. And I think this is a time for us as partners to start thinking about how we give content to the ask of increasing excise taxes on tobacco, alcohol, and sugar-sweetened beverages without focusing too much on the constructs of that industry and more on what we're trying to solve, which is a decent life for all South Africans and people who live here. A decent life where they have access to the healthcare that they need. And I think we argue that the best platform for that is strengthening the responsiveness of district health services across the 52 districts in the country in we live. And for us at RAP, particularly for rural communities, which continue to bear the burden of all these system failures over time and are also the first ones to see the impact of reduced funding at district health service level. So thank you again for taking the time out of your busy schedules to talk to us, with us today. And hopefully this can be the beginning of more deeper engagements on the health system that we want within the framework or the constraints that we already have. And hopefully the lineup today will help us give life to some of those substances. So thank you again.
Thank you very much, Russell, for that. In the interest of time, I won't even pull out highlights from what you have said. I think we will just go ahead and move on with our program. What's going to happen in the morning, this morning, is that we're going to have 3 presentations, and all of them in a way revolve around the issue of prioritizing, district health and resourcing at that level. So we will start, I would like to invite, and I won't be reading, just for you to know, I won't be reading people's CVs. I will also not be calling people doctor. I'll just call them by their first names. I hope that is okay and acceptable in the space. So please don't crucify me for it. But I really would like to invite right now Dashini from Priceless SA to give her first presentation. After her, it would be good then to have Mohammed Motala, and then we will have a short conversation after both their presentations. Thank you so much.
Do you need me to be here?
Oh, it's fine.
Yeah, sure. Thank you so much for that introduction. It was great coming early because I got to meet colleagues at RAP. So thank you to RAP for inviting me to speak on this important platform today. I know there are many economists, health economists, people who have worked at the district health level. So my talk today feels like I'm going to be preaching to the choir, but just based on the aspects that Russell mentioned, I think important to set the scene for today. Okay, sorry. Yeah, so not a good idea being the first because you learn all the technical, the ironing out begins with you. Okay, no worries. Just let's see. Okay, So as Russell mentioned, South Africa faces a persistent burden of disease in the context of tight fiscal constraints and the high spend on health, 8.8% of GDP. Recent data highlights that the burden of disease in low and middle income countries is rising faster than GDP growth. Data from health economists in the country, as some of you may know, Michael and team at Priceless, highlight that the economic cost to the health system for conditions such as mental health, obesity, and overweight in the range of 5 to 15%. And more recently, data from the Bushbuck Ridge area demonstrates the high out-of-pocket expenses incurred by patients with 2 or more conditions. And these are patients accessing free public sector services. So these are the indirect costs. So shifting these rural households deeper into poverty, of course. So Russell mentioned today, my goal is to reiterate the economic investment case for prevention. So there's a strong economic case for shifting resources upstream to prevention and early management, especially early in the life course. The shift is not simply an aspirational one, it is economically necessary. So it's recalibration to protect the sustainability of the health system. Prevention avoids the need for more expensive downstream services, such as avoidable admissions, preventing complications, and improving overall population health. Early detection and management of chronic conditions reduce long-term costs both to the health system and the household. Without a prevention-first approach, the system will be forced to absorb higher costs, worsening inequities, and declining service quality. Evidence-informed prevention investment choices for benefit design under the NHI is critical. The package needs to be assessed based on what delivers the highest health return per rand and advances equity in underserved communities, which is no easy task, as you may know. So now, going down to the district. So prevention makes economic sense for the district. Prevention and early management consistently offer higher returns on investment across multiple health areas. By intervening early, whether through community-based screening, routine PHC level management, or behavioral prevention programs, the health system can avoid costly hospitalization and long-term complications that escalate expenditures. For districts, this means reorientating services away from a hospital-centric model towards strong primary health care and community structures. Furthermore, preventative interventions restore productivity by reducing morbidity and preventing disability, thereby generating economic gains not only for the health sector, but also for households and the broader economy. And these gains, of course, compound over time. As shown by health economist Funeka Bango and team UCT colleagues, there's a high upfront cost often with preventative programs, particularly if you are targeting early in the life course. And we see that across many other programs in LMIC. However, those potential high upfront costs are often offset by costs later linked to serious SRH complications, linked to teenage pregnancy and school dropout. The return of investment for mental health prevention and treatment is clearly demonstrated in modeling work done by health economist Donella Besada and team at the SMRC, particularly highlighting the return of investment for school-based mental health screening programs, as well as for screening for common mental health disorders. Their work shows how shifting mental health services more towards community and PHC models of care can free up resources to manage and treat the more complex cases within inpatient care services. So if we did nothing about prevention, what would be that cost for inaction? So failing to invest in prevention, as you know, is far more costly than delayed diagnosis and treatment. Across diseases and population groups, the economic costs of unmanaged conditions are linked to loss in productivity, disability, preventable complications, and catastrophic household spending, which far exceed the cost of implementing targeted preventative programs. Data on the right show that inaction around youth SRH needs or mental health prevention in this population can cost the state an estimated 8 to 4% of GDP per annum, crowding out budgets for other needs. When districts defer early detection or underfund PHC capacity, they pay later through emergency admissions, advanced disease management, and expanded social welfare needs. The pay later and more cycle leads to budget pressure, worsening inequity and lower quality of care as highlighted. The bottom line is inaction is the most expensive policy choice. By investing early, districts prevent cost escalation and ensure resources are used where they deliver greater marginal benefit. So how should district level health systems go about priority setting? So districts need clear evidence-based processes for choosing which interventions to fund. But how do we get there? How do we support district managers? So the first step would be to begin with local disease data and to identify the high impact areas. Use cost effectiveness evidence, although we know it's quite scarce in our setting, to rank interventions by health gains per rand spent. Apply equity lenses to ensure investments prioritize rural communities, low-income households, and vulnerable groups. And align district choices with national financing reforms, including the future NHI purchasing rules. District managers should be able to answer simple questions around priority setting. Which intervention offers the highest value? Which populations benefit most? And what can we afford now? And how do we measure progress? By adapting transparent, structured decision-making tools, districts can build trust and ensure budgets are allocated to high-value interventions and reduce inequities and increase system resilience. Emerging data-driven platforms that are being developed, such as the evidence to decision collaboration with the MRC and NDOH, is one such platform with the hope that district managers would tap into to understand where what the evidence is showing around effectiveness and cost effectiveness. But it also involves including voices that are often missed in the health policy and research space. So much of this work also currently being done in the country around looking at sort of district priority tools being adapted for the setting, particularly rural communities, as shown by colleagues at Priceless for prioritization of community needs under the NHI. So as a health economist and someone who's worked at the district level, we know that it's not all about money. I think we all know that key towards district level priority setting is the strengthening of our governance and district level capacity around this. And of course, promoting resilience in our health systems. So when we look at governance, as colleagues have a study in press and they have shown, sub-districts are operationally central to primary healthcare delivery, as shown in their work in Ghana, but institutionally under-recognized. So modest delegation of financial and managerial authority can also unlock prevention performance gains. Work done by Lucy Gilson and team at the Health Policy Unit at UCT, they did a lot of work around resilience, and what they show is stable governance structures and adequate resources do influence everyday resilience, but they're not enough to sustain the health system. Instead, it appears important to nurture the power of leaders across every system and to help them reframe challenges. Their work shows that much of the district PHC level managers, much of their time is spent on managing complex HR issues. And of course, from a health economics point of view, that's taking up time by an important cadre. So just important to note that it's not just, priority setting is not just about getting the budgeting, right? It's also about looking at these other aspects of the health system, the software needed to sustain it. So I'm sure colleagues are going to go more into this, but just a quick brush over the high value interventions for district packages. So we know from the work done in the field of HIV/TB, scaling up integrated community models of care, such as mobile clinics, school-based services, and CHW programs deliver strong returns, and expanding equity, especially in rural and under-resourced districts. So a critical vehicle for that. Russell and team and colleagues at the MRC did this earlier study looking at the CHW program and showing how minimal in terms of PHC expenditure per capita, that sort of program and the returns on that. Other high value interventions, as we know, the integrated chronic disease model package, so improves patient experiences and frees hospital capacity. So costing of the integrated chronic disease model by Labina and colleagues was done in 2 districts in South Africa, Gauteng and the Northwest. And they show that there's fairly low average cost per patient visit, and that can be further reduced by examining the context in terms of implementation fidelity, number of patients accessing the services, and staffing costs related to the WBOT system. So we know we have an idea in our basket of sort of the high value aspects, what works, but how can we finance these and also look at integrated solutions for NCD management? So a large part of that is really about financing it through strategic allocation of existing budgets and maximizing efficiency gains where we can. So districts can achieve sustainable, substantial savings by shifting resources, as we've seen in the HIV/TB world, in terms of human resources, but also shifting it away from low-value inpatient procedures towards PHC and community-based models that allow for wider access and reach of hard-to-reach groups. It also involves some intersectoral budgeting. Work done by Gitesh and team at UCT and the MRC also show how innovative ways such as the private-public partnerships can help fill important human resource gaps in rural districts, especially around obstetrics care. As colleagues have mentioned, with the withdrawal of donor funds for community HIV programs, we also need to look at how we sustain the informal caregiver economy, which we know plays a major backbone in much of the HIV/TB programs and of course, the growing NCD burden. And recent work in the field is also looking at our aging population, the need to extend financial risk protection models of HIV care to other NCD and geriatric populations. Colleagues have shown there's oftentimes higher financial protection for those aging with HIV versus those without HIV. So I won't go into this, as I'm sure it's going to be the highlight of today, but Michael and team at Priceless have looked at this. And so the health taxes, of course, as you know, is the space that can help finance these innovative district health models. The revenue generated from sugar-sweetened beverages, tobacco, and alcohol not only reduce harmful consumption, but allow for that revenue stream that can be reinvested into our prevention and early management programs. As shown by colleagues in Priceless, just the tax on fruit juice alone, the substantial impact it can have in terms of savings on healthcare expenditure. Another key aspect to how we finance prevention is, of course, strengthening our district level data systems and supporting supervision at all levels. It enables to track the spend to impact and ensure funds are also protected even during periods of budget tightening. Prevention financing must be coupled with accountability frameworks so districts can demonstrate measurable health and economic returns. And alongside that, we need to support the use of our data systems, so to inform sort of the robust healthcare financing decisions that we have to make. And we need to leverage both our routine as well as our surveillance systems for district level planning. And we know South Africa has a landful of data systems in the country, and it's also about harmonizing across platforms. And lastly, there's a need for more locally based health economic tools. I think health economics in the field in South Africa in particular is faced with a challenging sort of period right now. We ask big questions, but we lack the basics in terms of tools, from quality of life weights to cost effectiveness thresholds, and to integrated financing models that can be used to sort of inform decision making at the various levels. And so there's a need to invest in that. And so in conclusion, so prevention is smart economics for the district. It saves money. District managers should see prevention as an investment portfolio, low cost, high yield interventions that when combined, they transform health system performance. Prevention and early management are not optional. They are the most economically rational choices for South Africa's health system, particularly for your underserved communities. A prevention-first PHC district model improves population health, protects households from financial hardships, reduces health system costs, improves equity and resilience. More importantly, it meets the health needs of the present and future populations. And lastly, to facilitate the district level priority setting that we hope to see in the future, we need to develop the financial governance and health economic skills of our managers on the ground. Thank you. I'd just like to acknowledge my staff, students, and our participants and the DOH and community funders. Thank you.
Thank you so much, Dashni, for that input and just highlighting the importance of early interventions, particularly that are not just about finance, but also, highlighting the importance of governance and accountability. I would like to now call, to the podium, Mohammed Matala from NACOSA to build on this, and he will be focusing on why should we rethink how we deliver TB and HIV services at a community level, and how could this change?
Thank you.
Do you need a mic?
The online people need the mic more than me. Yeah. Thanks. Good morning, everybody. And thank you, Darshini, for that lovely presentation. I'm trying to see where you are here. In terms of all the research and the evidence as to and building on what Russell said earlier on, if we're looking at a realignment in the current context, dwindling resources, where the money is going, the loss of the US funding that came into the health sector, but more importantly, in the community health systems. And my input is going to focus on that. So, and it's framed around some work that we did. We went to 800 poorer households, the poorest in Cape Town. We defined that by looking at the disease burden and the data that comes at the facility levels to identify 8 areas where we think deprivation, health care, and the conditions under which households are living and what's resulting in their poor health. So we went in there and did a survey of 800 households. We did focus groups then with people that are involved in that work. So community health workers, at a governance level, the district health committees, the health committees, also whatever governance structures at a local level, we're working at the community. So the community health systems and a definition of that, an easy way to think about it, is the link between the public healthcare sector and the poorer households. So we have a system that operates in our country where community work gets done. These are, and they're the people who chase up what's going on and understand deeply what the drivers of poorer health are in those communities. So in our work, these concepts, you've seen them everywhere. Universal health coverage, we talk about it a lot. NHI, all of these things say that communities are central to getting everything correct. Leadership should be provided by communities. And civil society in those communities try to organize those communities in such a way that all the wonderful things that come out in our policies, in all of these concepts like primary care and what the public health system should be doing, what community-oriented primary health care is about. These concepts and understanding them at the level of how do they relate and support community health systems. And I'll come to a definition of community health systems because I think for us at NACOSA, the drivers and our work is about strengthening civil society at that level in the community to work better with the public healthcare system, the private healthcare system, and all kinds of support to result in better health. Next slide, please. So to understand, we in this study that we did at NACOSA, and my co-collaborator here was also Dr. Magasela, who assisted with looking at the policy implications. Primary research. A lot of the research that Darshini presented was around the numbers, the figures, the financing, where the money is going, how we should use that money better, how if we focused on prevention, if you spent 1 rand on prevention, you'll save 9 rand in the health system. This is what UNAIDS kind of data looks at. Frontline AIDS comes out with data like that, saying for financing and prevention, if you spend 1 rand, you will save 9 rand. Because when people get sick, you have to look after them in the hospitals, you have to look at palliative care, you have to work on disease and all of that. So spend the money up front, prevent. But going and understanding the challenges that poorer households face in the city of Cape Town. That's what we wanted to understand. And we thought if we understood that, it would give us more evidence, direction, and practical things to address the kind of issues that were being brought up in the research. So what kind of realignment is being suggested? And my fundamental premise in all of this is that the defunding of community health systems is a problem, the shift away from that. So Trump and his government, and for all the horrible things they continue to do in the world, they did have huge financing in the form of USAID and CDC, and a lot of that work went to supporting community work that was done in community-based organizations around prevention, keeping people in treatment. More of that work is done by our government and the spending that we do and comes from our fiscus. But in this realignment, they are moving to safer spaces, build big, look at medicine. Lenacapavir is going to be a game changer in prevention for HIV. Spend that money. We won't talk about how much Gilead and the pharmaceuticals are going to make out of that deal and how that money is being spent. But the defunding and the underfunding of community work, practically it came about in places like at NACOSA where, for example, if I costed what it would cost to keep a child safe, because we had programs supporting vulnerable children, There were 18,000 children in the city of Cape Town. 5,000 of those were HIV positive. Our field workers would go to the hospital, check the records. Did this child come? Did the parent come for the HIV medicine? Did they collect the medicine? What's the viral load? And if there's a mismatch, if they collected their medicine but the viral load is going, they would go into the household and understand, hey, what's happening? Why is the viral load of the mother increasing? Why is the child not taking their medicine? In that follow-up and in that prevention work, it would cost NACOSA 1,500 rands per child to prevent that child from contracting HIV or that situation getting worse. The cost of lenacapavir as an injectable on the US pharmaceuticals is something ridiculous like $48,000 to keep a person free of HIV for the whole year. We're getting it at a cheaper price. There's a whole deal between this guy, Gates, and his friends Epstein, and we know what that whole story is about. Anyway, he came with the deal, brought some money into it. We don't know, Gilead's charging people $48,000 for treatment in the private hospital, private healthcare system in America if you went to a pharmacy. Rich white people in those countries can afford those things. Gilead needs to get lenacapavir over the line in the community setting. So deals get struck, we get the opportunity to have these doses. And so there's a huge lenacapavir program because the field testing, the community work, that part of the work, that's where they are. And then once all the pharmacies of the public healthcare systems of the big populations of the world buy their medicine, that's where they play the long game in all of that. But community health systems get defunded in this process, in the realignment. So my beef is around saying that realignment is, can we look at what community health systems are and how can we strengthen them? And are there opportunities to realign service delivery in that scenario? And what opportunities are created by prioritizing strengthening community health systems? Next slide, please. So going back to, I said we did a study and there were some findings and we tried to do some analysis of that. And in those, we found that the need is high for healthcare services, for the drivers of better health. And there were 8 support types. 55%, half the households, have a very high need for a kind of needs to get their health better, to have better food, to have better access to medicine, to have better governance, to have better follow-ups, that they don't miss their appointments, that kind of support. For more than half the households, that need was very high. And very, very high when 8 of them, when we asked them, what kind of support would make your life easier to be healthy? There were 8 areas.
So previously, there was a nationwide campaign.
So if there were 8 areas in the household where we consider that house to be highly deprived, if there were, so we 8 plus support, sorry, higher. So the next thing, our finding is that food insecurity is widespread. We know the general statistics in our country. 50% of the population is living in poverty, less than $2 a day. 25% of the population is living in extreme poverty. What is extreme poverty? When we do household work and we go community work, we go into the house and we ask, so can you show us the food in the house? And they show us the cupboard and the cupboard is empty. It's not like our pantries at home where we've got food at least for a week. We know it's empty. When we look at and ask questions around, did the children in the family skip a meal in the last 7 days? They say yes. Did you have to share meals? Do you have meat in your diet at least once a week? Deep, extreme poverty. Children are poorly dressed. There's no food in the house. Conditions of overcrowding. Go to any of our informal settlements you know the conditions under which people are living. There is serious food security, leads to stunting in growth, all kinds of knock-on effects that result in poor health. Access barriers persist. So 20% report difficulty when they access services and care when they need it. And what do we mean by that, access services? So there were about 21 things. The queues are too long. I can't go to the service because the clinic is far away. It's not safe for a woman to go after hours, even though the clinic is agreeing to open till late at night. Access barriers, communication. That security guard, he doesn't even let you go from the front. He asks you, the forms that we are filling in terms of the admin work that goes, when did I miss? The queues are to access barriers. 20%, almost a quarter of the households say they have difficulty accessing care when it's needed. And close to 30%, close to a third, meet the clinic access barriers indicator. We developed an indicator to say that this is what we would call a clinic access barrier. Close to a third of the households say those things are related to that level of care. This, and Russell speaks about this, where the continuity of care. Our problem is not more than, or we do have a big problem about people falling off treatment and losing people in the system. So in as much as we are enrolling people and finding the lost people in HIV and in TB, that's where most of the work comes. We are losing people. So continuity of care. Why is there no follow-up? Why is this person who we are saying, here's free medicine, here's the clinic, but we are finding that there's the problem with continuity. So what's happening with the follow-up and what's the barrier to the follow-up? How do we follow up? Cell phone, phone the person, that the phone is not there, give you an appointment date, you come for it. After 3 times, you miss your appointment, you go off the list, you go back at the back of the queue. People get tired of that. In our economy, people are having informal jobs, so they send uncle or aunt to go collect my medicine for me on that day. There are system problems there, and these are the things that when in his input he was saying, so what can we tweak? How can we go back home and fix some of the practical things around continuity of care, community work, community health care system? Who is doing that follow-up and helping that person? It's a community health worker. It is a family person. It is a relative. Those systems of care that are operating, how can we strengthen that? Follow-up through gaps are concentrated. 15% meet the follow-through and feedback gaps indicator, peaking in Mitchell's Plain and Khayelitsha. Interesting thing, starting to pick up on the differences in areas now. And this is why a local approach and community health systems that are working at a local level understand what are the issues in that local. It may be, it's like in education. Sometimes you have a marvelous principal, a good teacher, and that school flourishes. And next door you have a school with the best facilities, the best technology. It's got a science lab and all of that. But the matric pass rate is sometimes better in this school where the relationships between the principal, the parents, the teachers, the students, governance is much better. We learned this lesson, for example, in COVID. Different countries had different approaches. Some relied on medicines, some relied on, controlling people. But there was no direct correlation between which was the best approach. And at the end of it all, the jury is out on what happened in Africa, because when we saw what was happening in New York and the rich countries in Europe, we got into a shock. It's going to be chaos in Africa. But we didn't see that in COVID. Community health systems kicked in, where there was no injections. We had, what did you call them? What were those injections that we were all taking? Vaccines, yes. Those hoarding of those vaccines, the European countries kept them, the rich countries didn't want to share them with us. We didn't have them, but we didn't collapse in Africa. We didn't fall like flies, we didn't in the numbers. Whether the numbers are true and we don't know, there's a hidden thing going on and we hide the suffering and the death. Because when it happens in some countries, we flash it across the TV screen. When it happens in other countries, it's hidden. So we don't know. There's a story around that. But somehow, somewhere, communities, community health systems, support at a local level, those kinds of things. Support instability is frequent. At least one support type is lost or reduced. Part of the research we did was we asked in those households, what did you have in 2024? What did you lose in 2025? Because there was a big story around all this funding disappearing. And what do you need in 2026? We did that kind of. The problem in the administrative data at the clinics and everywhere, that data is not coming through yet. The impact of the loss of this funding and what's been the direct numbers, whether politicians are also not being very open about the impact of the loss, because the position is that, no, we pick that up. We don't need, they're playing their own politics, geopolitics. We don't have to be so reliant. We pick that up. Our healthcare system, our clinics have picked up that. Those 18,000 children that you were looking after as NACOSA and the 5,500 children that were HIV positive, we reintroduced them into the public sector and it's all fine. But if we ask for the data, there's a lag in that data at the moment. I've spoken about food, big thing. You can't take medicine if you don't have food. People in HIV, TB will know that. You can't. And so if you have food insecurity to the depths that we have in our household, forget about lenacapavir medicines, all the line the people up, give them injections and they'll be safe. If they don't have food, if they don't have the determinants of health, the drivers, income, unemployment, people have to buy food. They need money. So if you have the unemployment rates we have, so these things come together and understanding what is coming together. In some areas, it's safety and security. Cape Town, gang violence, can't walk around. Once it gets dark and the days are short in winter, you only have light from about 7:30 in the morning till about maybe 5 o'clock. Daylight hours are limited. Women, other people generally can't walk around safely. So safety and accessing services, safety and getting income, those kinds of things. The top priorities for 2026 cluster around health access and continuity, the big finding for us. Improve the access and start to pay attention around continuity. Clinic health care when needed, 83% said that. Regular medication supply, what is regular? It must be local, it must be easily accessible, we must get it when we need it. And it mustn't, there are these things of stigma. I don't want to tell my uncle's friend who's got a car is passing by the clinic to collect my medicine, because I don't want everyone to know I'm HIV positive. We're still dealing with those kinds of issues in our society. So how do you make that accessibility? And when you say things are not accessible, understanding the complexity of it all. Safety, I've spoken about. Security mediation, example, neighborhood watch, CPF, violence de-escalation, those kinds of things high, 47%, almost half say safety is a problem. Clinic admin help, queue support. You know when you go now to the bank or when you're boarding an aeroplane, somebody comes in the queue, that queue is being managed. It's being sifted to say, oh, this problem we can solve in 5 minutes in that line. This problem is going to take 3 months, that queue. So even when you go for your IDs now, there's proper queue management, and getting simple things like that going in our local facilities will go a long way to shortening those queues. It's a simple management thing. It's a simple trust thing. It's a simple having good sort of management. Water sanitation, we know that story. Help from neighbors, informal networks, 35%. Now, who's looking after poor people and poorer households? Food, soup kitchens, church groups. Households are surviving on that kind of support to be able to get that. And what are those networks of support that in the, where is it? Help from neighbors and informal networks. 35% are relying on that because there isn't the system that's holding them. Across the 4 system functionality lenses, the areas most exposed on combined indicators, this was just getting deeper into what is the story in the city of Cape Town. Khayelitsha, Mitchells Plain, and Delft. Out of the 8 areas. We also had District 6, we had Dunoon, we also had Guguletu and that kind, those areas. You can skip this slide and go to the next one. So 2026, what are your top priorities and delivery? People said, clinic care when needed, 83%, focus on that. Regular medication supply, half of the households need that. Safety and security, 47%. Clinic admin, I've spoken to these issues, but this is the data which came out in our study. How priority support should work on the right-hand side. I have spoken to those issues, and we can go to the next slide, please. This is just a deep dive into one of the things where I spoke about the queues. It's a routine pickup, there's a missed date, you get a 5-day grace period. What happens in those 5 days? The buddy or proxy pickup is not working, there's a disclosure risk, people are being turned away, you get sent back to the queue. You start all over, and then you come to it. So there's data and evidence as to how to sort of fix that kind of issue. It was a deep dive. We wanted to understand why are there breaks as to why people are not continuing with their treatment. Next slide, please. This is showing local areas and how the blanket approach can't work. And these were the 8 areas. The 6 areas: access, continuity, food, follow through, and community health worker visits. So if you look at Delft, so in Cape Town you have Afrikaans speaking poorer communities, and then you have Xhosa speaking in poorer communities. Khayelitsha, Xhosa speaking predominantly, Guguletu, Xhosa speaking, and then Mitchells Plain, Kraaifontein, to an extent Delft. So you can see that between black and brown people, they do have common problems in Mitchells Plain as well as in Delft or in Khayelitsha, food insecurity. So they may be different culturally, they may be speaking different languages, but the economic situation is similar and the need is similar. Other things like access to care, in Dunoon it's high, in other areas it's not so high, but a cautionary note on this in the way that we only went to 100 households, and in our sampling, some of it, there are even pockets in Khayelitsha, there are pockets in these areas, and we geomapped the household, so you'll be able to get the granular. And you'll see in some areas, it's like the community health workers are cycling around that area a lot, and so the care is better there. The other one has got a clinic and it's close. Some of the things where it is counterintuitive, you would think if you lived close to the clinic, your access would be great, but then there are other things. It's what's happening in that clinic. So understanding deeply at a local level how the community healthcare system is working is where we are pointing to. Next slide, please. So I use this word a lot, community health systems, and here I'm trying to give us an understanding of what are community health systems. And the timekeeper is reminding me my time is up, or do I have 2 minutes? 2 minutes. So this one is dense because it's saying people, organizations, relationships, and local mechanisms that help a community prevent illness, promote health, detect problems early, including pandemic preparedness, and connect people to care, especially outside hospitals and clinics. They are anchored by healthy community assets. A lot of suitcase words there, but practically what do they mean? Networks of peer supporters. We know about adherence clubs. We know about youth peer educators. We know about key population peer navigators. In sex workers and people who use drugs, key populations, you can't rely on it is peer work that survives and drives that kind. So investing in that, networks of peer supporters, community-based organizations, CBOs, they're delivering services. These healthcare workers are employed by CBOs. Psychosocial support, service delivery, advocacy. Local leadership and governance, ward committees, traditional leaders, community health clinics, clinic communities. So I'm saying that there are working definitions of community health systems. These are the components of community health systems. And so it is possible to focus on them, find the policy interventions, direct the budget into community health systems. I think I'll leave it there, colleagues. Thank you very much.
Thank you so much for that insightful presentation. And also just stressing how when you prioritize, you really have to have a nuanced approach to how your intervention is going to reap the benefits that you're looking for. I would like to open this up to you and to those who are online. If there are any questions to the first presentations that were made, please, there is another mic, a roving mic at the back, and I'll share mine here in the front. If you have a question, please raise your hand, and my colleague here will also let us know if there are people online, if you have a question or a contribution that you would like to make.
I think my question is to the first speaker. So she introduced the syntax and PAC re-engineering. And if we go back to the first minister's work in the Department of Health, we were looking at PAC re-engineering, wall-based. We had all these Cuban doctors coming in and trying to get into that model. Are we wanting to go back to what was originally, because it's something that was started and it was stopped? Because if we're going to have these finances coming in through the syntax and looking at how the primary healthcare system is at the present moment, looking at the systems that are there, and you rightfully said the sub-district management team has not been really capacitated to manage in a way that it's more of a crisis management. And I like the way you said they're more on HR and just getting the cues, but it's not a in-depth management of actually understanding in your catchment area, what is the disease burden? How can we go around improving? And if we can just go back to the basics. So I just want to understand, is that what she is thinking of when she says we use the finances from the taxes to realign and go back to PAC re-engineering in the format that it came and was introduced to South Africa, because it fell apart. I know in Gauteng that there was just one ward-based outreach team. I mean, not even outreach team. What is it? Those I've forgotten what they call those small clinics that are supposed to be a gateway between the community and the clinic. It was in Rosebank. It was piloted by one Cuban doctor, but that was the only thing that actually was implemented. But the whole PAC re-engineering is something that has fallen out of the way. We are more hospice-centric, and I want us to be clear on what we want to happen. Do we want to go back to re-engineering, take those finances from the taxes that we are coming up with to go and fund the re-engineering and the community health workers? Because currently the minister is, I mean, from National Department, they've said they are appointing all community health workers within all provinces. Are we then going to use that model? Because already we have the foot soldiers on the ground, but really look at capacitating PAC re-engineering and ensuring that the data systems are in place. I think that's just what I want to be clear on.
Thank you. You got that, Dashini? Great. I'll come back to you. Just keep that question.
Well, I suppose I was going to, Darshini can go and I can go, or...
No, you go. Dashini will... Are you answering, or
yeah,
are you asking a question?
look, I think we're adding to this conversation,
Okay.
right? Because this is really... And so I want Darshini to start, and then...
Okay, then
Then
that is
we
the
can-
case.
Uh,
Okay, go ahead then, Dashini.
Thank you for highlighting that. And yes, all the effort that went into PHC re-engineering, as you know, definitely many of us saw on that table around benefit design, without giving too much away, are championing that. As much of the conversations around district health system strengthening in the benefit design sort of work under the NHI is sort of fallen away or not prioritized as yet. And as you highlight, we already have these pockets of good practice that we know, and it's about leveraging that to inform the future benefit design. So I think it's definitely something many of us are championing, and we hope it will continue to be front and center in the NHI design. Thank you.
Okay, before you come in, Russell, is there another question in the room?
And just to say that the taxes alone won't be sufficient, of course, for this, right? It's just one stream of financing that part of a big, bigger pool of other revenues that we need. Thanks.
Thank you. Is there another question in the room? Please ask.
Sure. Thank you so much. Sort of just in terms of trying to plug that revenue gap, one of the sort of recommendations but was on public-private partnerships. And there's so many different types that are possible, and each come with different matrix of risks and benefits. And I just want to know if there's any specific ones that you guys are looking at or would advocate for.
Yeah, I think informing that discussion, there's still, I think research around that's still around in infancy. And as you can see, it just started in terms of evaluating the best practices around that, what we need. But it's definitely taken off in the Western Cape, as you see, and some other areas in the obstetrics care. And I think the more we see in terms of data coming out, the more we can advocate for that.
Okay. Any question? Additional questions? Okay, here we go.
Okay, I'm going to probably just come into the conversation now, partly because we're not offering that health taxes are the panacea to fixing all health systems issues, right? Nor are we advocating actively for the NHI, which I think is 5-10 years away. I think what the main conversation is that we are at a critical inflection point in our health system now, right? One, we have a government of national unity, so we won't have any other taxes, no increases in corporate income tax, no personal income tax increases, right? So the only space where we can actually actively engage is on these direct taxes. So we need to remember that health taxes, again, or excise taxes on harmful products, we're hoping it becomes health taxes rather than sin taxes, is a direct mechanism. In the first instance, what does it do? It raises the price of alcohol, of cigarettes, of sugar-sweetened beverages. By raising the price, the logic is that it reduces demand. Right? When it reduces demand, it reduces health system costs, both now and in the future. Right? And then over the long run, or in the immediate term, it raises revenue. Right? So just for instance on alcohol, if you just increase the excise taxes on beer, which makes up 70% of what we consume or imbibe as South Africans, we could actually raise significant revenue, but it won't fill our funding gaps. The core is that the way that we organize at the moment is not fit for the challenges that we face at the moment. Treasury has told us there's no new money. Find the money within your budgets. So we're saying, okay, fine, we'll find the efficiencies. But we also need to demonstrate that within the existing health provision, we don't cover cancer, we don't cover diabetes, we don't cover mental health. So there has to be an element of expanding it. So in many ways, we need to take a step back, forget about everything that's happened until now, and just look at this moment. Right? How do we ensure we keep 6 million people in care and raise that to 7 million? How do we reduce the number of people who are living with diabetes but don't have treatment? And so forth, right? And I think how it gets organized is the conversation. The health tax is just like Darshini says, is one part of the argument. And it contributes a lot to that prevention. But the debate today, or the discussion today, is saying, is this the tool? But in order to take advantage of the tool, we need to demonstrate what is the need. And I think both Darshini's presentation and Mohammed's presentation in that respect help us to sort of color within the lines. Thank you.
There are two more questions. We'll just take those. Thank you, Russell, for that.
Thank you. Good morning, all. My name is Kugan Pillay. I'm a governance and human rights advocate. And as we all know, listening to Mohammed's presentation on the challenges that facing the country, especially in the healthcare sector, but I just want to add to Russell's input on how do we think out of the box on accessing the budget that's so urgently needed for such a critical need and a critical policy goal. So, as I mentioned, I'm a governance and human rights advocate. We have lovely rights in the Bill of Rights and the Constitution, but it will not be realized if we do not have good governance. And as many of you know, the 1994 miraculous moment was derailed by state capture and corruption. We're seeing how vulgar it is when we witness the Madlanga Commission. So in this regard, I'm working on a few strategic initiatives. So I mentioned it's a comment and a question. And one of them is on the establishment of an international anti-corruption court. And I'm working closely with Justice Goldson amongst other colleagues locally and internationally. And it will focus on not just prosecutions, but asset recoveries. And you know, it's been established that, or estimated that we've lost during the state capture period in excess of R1 trillion. And as much as we talk about the sin taxes, that's your cigarettes, your alcohol, and also your sugar drinks. As the colleague said earlier, it amounts to a crisis management. And I think we need to look at it from a more proactive point of view in terms of what is required to achieve these Bill of Rights, especially health. How do we make sure we get all those illicit funds that's leaving the country? And we have to address corruption holistically. So as I mentioned, so some of the critical points we're looking at is asset recoveries. And in many cases, funds that have been looted during the state capture period, that's continuing. And then there's also the aspect of whistleblower protection. And many of you know we've lost Babita during the COVID period, but there's many others that speak out and are being targeted. So I just wanted to add that. And the question again is, would this aspect contribute? Because you don't want to look at it as much as it's a crisis, how do we bring it and to government's door and say, we need these funds, what do we need to achieve, what funds are required, and how do you do it? I think the president started off this year on a bad note by announcing increases in salaries. And then a few weeks later, we have the State of the Nation address, as opposed to talking about the state of the nation and what is required to address it. And I think from a moral perspective, you would have got a lot of accolades if you said we can't justify salaries amongst executive. It's not just in government, but it's also in the private sector. And these increases could have gone into a fund to help this critical need. Thanks a lot.
Thank you for that. Yes, one more. We'll take one more and then go back to our program for now, and we'll have another discussion later. Thank you.
Thank you. I'm Ian Cooper from Rural Health at Stellenbosch University, and want to pick up on some of the comments. The first thing that, unfortunately, this discussion makes me feel very old, because when people talk about primary healthcare re-engineering as where we started, no, primary healthcare engineering was trying to take us back to where we started. Primary healthcare engineering came in the 2000s. 1994, when we started, was actually for a model that's based on primary healthcare. That was the ANC health plan, and the plan that got derailed that Kuben was just talking about now, and a true district health system. And the problem is that we are not focusing the finances around districts, and that's why I appreciated Darshini's and our colleagues' presentation so much, that focus in terms of the district health system. But the challenge is, how do we get that prioritized? And I learned an incredible lesson from a colleague in the School of Public Health at WITS when I was still at WITS, who was a nephrologist, a specialist in kidneys. And he did a PhD in public health. And his realization in doing that PhD, he said, I realized to save the kidney, I had to give up the kidney. What he meant by that, to deal with the problem of Chris Hani Barra, dialysis not being able to keep up the numbers, he had to go into the community, work at district level on prevention. And that's making tough decisions, because you've got that huge load of people needing dialysis, but you are never going to meet the need for dialysis if you don't actually address the prevention that we've been hearing about. And it's those kind of tough decisions. And it's absolutely that health taxes are not going to help us, because if they work, actually, the taxes will decrease. That's what we want. I mean, another level, we don't want that. We want people to carry on with their so-called sins that we get enough taxes to fund. But I mean, that's a ridiculous notion that we have. And I think the governance that Kuben mentioned is so important, but governance at a district level as well. I have a colleague in the Western Cape who has stunned and irritated and frustrated many of the colleagues in his district, because he says, I don't have anything that I still need to do in terms of my operational budget in my district hospital. Yes, I need capital, yes, I need human resources and some, but in operation, in terms of the way that he has managed how expenditure happens in that hospital level, he says he doesn't need to buy anything that he doesn't have already. Now, how do we get to that level of government? He's saying we've got enough money, which everybody else in the district is saying, shut up, don't say that, you can't say that. But he's saying if you manage it properly, he's got enough money. The only thing I want to add, and that's maybe a question, we've heard continuity a few times. Have you done work around the cost saving of continuity? I've been in a situation where a colleague, a family physician colleague, was stopped from introducing continuity in their district hospital by the manager. This is because it's taking time, it's wasting time, but actually continuity saves time, not only because of relationships, but you get fewer investigations, you don't get things repeated, you don't get things getting lost, etc., etc., etc. So I really think work around cost saving of continuity is something that would make a big difference. Thank you.
Wow. Thank you for that. We have a question online. Not yet? Okay, there isn't a question online. Is there a hand raised? In the chat? Yeah, apparently there isn't anything. She's monitoring. In the chat area? She's insisting there is nothing. But we are going online now. We're just going to move straight to Salome. Is it? Yeah. Salome Meyer is with the Cancer Alliance. She's contributing to the same conversation that we have been having just slightly more focused on cancer at district level. So I'll hand over to you, Salome, Mayor from the Cancer Alliance. And are we
Thank
able
you.
to see you? I see your presentation, but I don't see your face. Are you able to show us your face?
Yes, I'm able to show my face. Good morning.
Okay, just so that yeah, thank you. Okay, good morning, Salome. Thank you.
Good morning to everyone in the room, and thank you for the opportunity to share my experience as a cancer activist in the pursuit of equitable cancer. Louise Turner from the Breast Health Foundation is attending the symposium in person on behalf of the Cancer Alliance. I have worked in cancer care for the last 30 years of my life. First as an advisor, then as an advocate, and now as an activist. Next slide, please. Apologies for that. So as Nelson Mandela reminded us, injustice anywhere is a threat to justice everywhere. Across Africa and in South Africa, we know this reality all too well. Where you live often determines whether you live. Cancer outcomes are shaped not by biology alone, but by geography, income, and health systems design. And I think the previous speakers have absolutely paved the way for what I am going to also share with you with regards to cancer. There is a next slide, please. There is a fundamental difference between equality and equity. Equity treats everyone the same, and equity responds to different levels of need. And justice requires equity. The key question for us is, what is justice then for cancer patients? Is it fair that patients are sent away from a primary healthcare facility with only a Panado, just because the healthcare provider doesn't know anything?
Okay, let's see what we can do with that.
You have a problem?
Okay.
Can I continue?
Salome, can you hear? Yes, please do.
Okay. What is justice for cancer patients? Is it fair that patients are sent away from primary healthcare facilities with only a Panado? That's when a healthcare provider doesn't know anything about the symptoms and signs of cancer. Is it fair that cancer patients have to wait for more than 6 weeks for results, let alone for their treatment? We know that access to cancer care depends on the 4 pillars, and it's not only cancer care, but it's also all diseases. That is availability, affordability, the quality of care, and the acceptability. And for us, this should be across the entire cancer continuum, which is prevention, diagnosis, treatment, survivorship, and palliation. At the Cancer Alliance of South Africa, we apply a human rights-based approach to advocacy, which is evidence-based, transparent, and independent. We use our reports for solution-based advocacy. Slide 4, please. Next slide. To make sure that we are all on the same rap sheet, let me briefly describe the differences between cancer and other diseases such as HIV, TB, and diabetes, of which we've heard a lot this morning, that can be managed at a primary healthcare level. When we refer to a person that has cancer, you have to be specific. Cancer of the what? Each organ is a different cancer. There are more than 300 different cancers. Each cancer will be unique, as there is no one shoe fits all approach. There are different causes for cancer. These could be cancers caused by a virus, such as cervical cancer, caused by the HPV virus, and liver cancer caused by the HBV virus, and that's hepatitis B, that are preventable with vaccines. Then we have cancers that are hormone linked, such as breast and prostate cancer. We have cancers that are caused by environmental and lifestyle, such as lung and colorectal. Mainly, it will be the older generation that are affected by cancer. However, this also is changing as a result of a modern lifestyle of fast food, inactivity, and many other factors. We refer to the continuum of care that starts at primary prevention, with aspects such as tobacco control and vaccination, which is the discussion of prevention that Adishini shared with us. Awareness and education at a community level by health workers that work in communities and understand community challenges. Again, here Mohammed actually shared some of their experiences. Early detection at a primary healthcare level by healthcare workers that are trained, screening and diagnosis that is followed by treatment with supportive care as well as palliative care. Most of this happens at secondary and tertiary care levels. Cancer is also a treatment with more, or a disease with more than one treatment modality. It is not a matter of take your pills or your injection and then you will be okay. The treatment modalities of surgery, chemo, and radiation therapy requires highly trained specialists and equipment and chemotherapies that are expensive and mostly not even available on our essential medicines list. And lastly, after heart disease, it is the second highest cause of death in South Africa for non-communicable diseases. Next slide, please. I know the slide is quite busy, but let us just take a quick look at the burden of cancer in South Africa. The slide tells you about the top 10 cancers for males and females. Cancer is a registrable disease, with the National Cancer Registry being responsible for the management of collected data. It is, however, only a pathology-based registry, noting that not all cancers are diagnosed or confirmed with pathology. This leads to an underreporting, and it is estimated that there is a 40% underreporting, and also not all laboratories report to the National Cancer Registry. Despite all of this, in 2023, the latest available data set, which you have there on the screen, a total of 87,853 people were diagnosed with cancer. Now just add the 40% that is not actually recorded. We do not know the survival rate, as death statistics is not linked to the National Cancer Dataset. Survival rates are important as it tells you how good you are in managing your disease. With data sets that are incomplete, it therefore remains difficult to plan and to budget appropriately for exactly the cancer care that we would want to have at a district level. Next slide, please. The slide shows you the top 10 cancers for the different 4 population groups. And again, this underscores the difference between where you live will determine whether you live for most people. Just note the high incidence of cervical cancer amongst Black women. This is despite the fact that we have a cervical cancer screening policy in place for many years. But we also know, and this is at a primary healthcare level, and we also know that the policy implementation is severely lacking. If we reach 35% of our women, we are lucky. Breast cancer remains high. However, we also need to say that there is a lot has to do with awareness, education, and early detection. Note that non-Hodgkin's lymphoma is also associated with HIV. We know that a low immune system is a high risk for specific cancers. Next slide, please. The slide shows you the cancers in the male group. Prostate cancer remains our biggest concern in all population groups. Again, the differences between population groups tells us the story of access and specifics that has to be taken into account when we plan for cancer care services. Also notice the HIV-related cancers such as non-Hodgkin's lymphoma, corpuscles, and also cancer of the penis. Next slide, please. If we now focus on cancer care services, we know that in South Africa, we have one of the most unequal health systems in the world. 86% of the population uses the public sector and 14% use the private sector. Yet in oncology, 80% of oncology professionals service exactly that 14% that access the private sector. And that also goes for equipment. And hence we have a court case against Gauteng Health Department. Our incidence for cancer is increasing, despite the fact that we don't have appropriate data sets. But so is the cost as well. And it is projected that by 2030, we would require more than 50 billion to manage cervical, breast, prostate, lung, and hematological cancers only in the public sector. That's not even talking about any of the other cancers. Hematological cancers are of the most expensive to treat and could be managed effectively at a primary healthcare level. We only have screening for cervical cancer in place at primary healthcare level. The breast cancer policy was approved in 2017. However, this policy remains unimplemented in all provinces due to budget constraints. The prostate cancer policy was started, yet never completed. It means that our men goes without screening. A lung cancer policy is also in place, but not implemented. And the same goes for colon cancer. In fact, there's nothing in place. And what we also have as an added burden is that patients with stoma care, and that's where Russell's point of dignity comes in most provinces only have access to 5 stoma bags a month. 5 a month. That means for the rest of the time, you have to, as Faisal will call it, MacGyver a shopping bag. Treatment of cancer mainly happens at our tertiary levels. The impact This impacts patients as rural patients have to travel long distances and often have to take leave or risk losing their work to stay alive. Next slide, please. Unlike HIV and TB, that was prioritized many years ago, with only one directorate that coordinate and manage this disease, or these diseases, cancer is managed across many divisions at national and provincial level with no coordination, and it is not prioritized. Treatment guidelines are not standardized, which means that a patient in Limpopo will be managed differently than a patient in the Western Cape, which in any case is managed as a different country from a health perspective. Most patients in the public sector are diagnosed with late-stage disease, that is stage 3 to 4. These stages are difficult to manage, are costly, and also have a poor clinical response. Early detection with proper referral pathways will change the outcomes for patients and also for the country from an economic perspective. People with early stage disease can be active citizens contributing to the country's economy, while late stage disease patients will become a financial burden on the system and on their families. Most patients do not have the luxury of being treated in their own home language, as most clinicians are not conversant in the language of their patients. The word cancer doesn't even exist in many languages, and something like radiation therapy is difficult to explain. In some cases, it is translated as to burn. Now, how do you explain that? Treatment for cancer is prolonged, which does mean that patients have to balance their circumstances and cannot function properly. Ask any patient that has been on Red Devil for chemotherapy how they feel after the second round of treatment, and they still have to face many more. Your life changes completely, and most patients have limited or no palliative and supportive care, which means that they are left to their own or family resources, physically, financially, emotionally, and mentally. Next slide, please. To ensure that cancer is a district priority, our call to action is: cancer must be recognized as a priority. The same political will that we afforded to HIV and TB must be afforded to cancer. We cannot have the situation of where you live, that we leave people unattended with cancer. When AIDS became a national priority, a National AIDS Council was established. Now we demand the same. Establish a National Cancer Institute, which will be coordinating body that will take the responsibility for equalizing the playing fields with standardized treatment guidelines between the public and the private sector, ensuring access to care using data systems effectively to project, plan and budget for cancer care, and ensure that healthcare professionals are equipped to manage the epidemic that is facing us. We can no longer afford to work in silos. We need to integrate NCDs and cancer in our HIV and TB programs. We cannot afford not prioritizing this, such as what happened in round 6 when the principal recipients of the Global Fund deprioritized cervical cancer screening and returned the money unspent to the Global Fund. And now, in round 7, we sit with the same inaction. No, this is unacceptable that we have this kind of attitude about people's lives. We need to invest in our community health workers and traditional health practitioners. They remain the foot soldiers in our community for education and awareness. And again, the focus should not only be on HIV and TB. Cancer screening should be included in the ideal clinic framework. That will require that we ensure that healthcare professionals are trained and that there are appropriate referral pathways for diagnostics and treatments in place. We can decentralize cancer care. It is not impossible. Medical officers at secondary level will make a world of difference. This should be coupled with surgical capacity for cancers that can be treated effectively at this level. Just this investment alone will save a lot of money in the future treatment budget. Our focus should be to improve survival and the lived experience of cancer patients and their families. We can change the outcomes. Last slide, please. In closing, there is a practice amongst cancer treatment centers to ring a bell when the patient has completed their treatment. Every patient wants to hear the sound of that bell and in fact want to go and ring that bell. It should not be something that is impossible. We still have much work to do. Equitable cancer is not charity. It is justice. It is a human right. And it is a shared responsibility. Thank you.
Well, thank you so much, Salome, for that. I guess that last message on ringing the bell and where you live determines whether you live. That will just stay with us, I think, for quite a while. And I think also it links up with what Mahomet spoke about earlier, which I will just phrase differently, that it's not just where you live that determines whether you live, but it also determines if you are understood, if you are heard, if you are seen, if you even access the health that you need. So we are running somehow behind time, and I know that there may be questions for Salome. And I was wondering, Salome, if you will be here after tea, so that you take up a few questions after the presentation on understanding health financing landscape and its options, so that what you have presented to us here is integrated as part of that, because I think the key question still remains about whether health taxes can be part of the solution, and if not health taxes, what else? So would that be okay to take questions and be part of the next conversation?
I definitely will be available. I'm joining the session for most of the day. Thank you.
Thank you so much. If you allow me, may I suggest that we break for tea for 15 minutes and come back in the room. What time is it? It's around 11:20 on my watch. We come back at around 11:35, which will be less than 15 minutes, sorry. And then we will start the next conversation. Is that okay? Okay, fantastic. 11:35. Thank you so much.